out of it. As you can see, I would only highlight one thing that ma'am has written in this first slide. Lot of achievements, lot of publications. No need to mention all that. Everybody knows ma'am so well, but she's a distinguished teacher and has received an excellent award by the national board. And that is just one thing. I think ma'am is, represents the interest that she has in teaching. And I'm sure that everybody would enjoy learning from ma'am, especially about PCOS, where we deal with so much of cases every day in our OPTs and while you are doing your fellowships. But resistant PCOS is and stubborn PCOS is something that everybody has to listen to Dr. Abha, how we manage such cases, and how difficult it seems, but how easy it is to manage these cases. So, ma'am, please
Madam,
enlighten us about PCOS.
Madam, 1 minute, 1 minute. I have to tell my support team to start recording.
I already started, sir. I
Yeah,
already
I
started.
can see.
Yes, sir.
Okay.
Thank you, Tejashree. And I'm so glad that we've taken this initiative. And this was on the request of some FNB students, some more gynecologists who time and time again would want to join our classes. But now we don't have Zoom classes. We have physical classes. So I thought if every Thursday I could take one clinical class, which all of us who do clinical practice, whether it is IVF or non-IVF, but infertility related, this could help us. Now, PCOS, it appears very easy that you give letrozole, give clomiphene, give gonadotropins, and they'll respond. But all cases are not so easy. So if we understand, should I start? Everybody is ready to listen to me, can hear me well?
Yes,
Tejashree?
ma'am.
Okay.
Yes, ma'am.
So ovulation disorder in PCOS are either infrequent ovulation, which is oligo-ovulation, or there is complete absence of ovulation or anovulation, and for months together, the patient neither ovulates nor menstruates. And if she has bleeding, then that is just estrogen bleeding, which is a breakthrough bleeding on an endometrium, which is building up only on estrogens. So most of these women are not absolutely infertile, but they are subfertile. But we encounter a complete spectrum of ovulatory dysfunction in PCOS. On one end, on the smallest or narrowest side, there is sporadic ovulation and one may conceive naturally. And these women don't even realize that they have underlying PCOS with irregular periods also. And the other side of the spectrum is often challenging to treat these PCOS women successfully and safely with various ovulation-inducing agents. Now, because this forum is of gynecologists, all are well-read, so I thought, let me bring some evidence also when we are treating our patients. I was a great fan of using clomiphene citrate, but the evidence now says that letrozole is the first-line drug for anovulatory infertility, with second-line treatment consisting of clomiphene citrate alone or in combination with metformin, gonadotropins, or ovarian drilling. Why is it so? It is so because letrozole is very safe. It rarely causes multifollicular development, which can happen with clomiphene very commonly, especially in a very sensitive PCOS. If we give 100 milligrams of clomiphene, I have landed with a pentaplet pregnancy once with just 100 gram of clomiphene. So letrozole is very safe, and hence it has become the first-line drug for anovulatory infertility. This is international evidence-based guideline for the assessment and management of PCOS 2023 summary. And I've taken these lines from that if there is an absence of an absolute indication for IVF, because normally PCOS is not an indication for IVF unless we are making the woman ovulate many times. She has timed intercourse or even IUI and nothing works. Then we go to IVF. And here they still bring in vitro for women who get hyperstimulated on stimulation. We can put this aside, IVM, we can leave aside. We can now concentrate on what the recommendation is. Now, I'm just highlighting few recommendations. Metformin is a drug which can be used, but it is not a ovulation-inducing agent. It just brings the metabolic disturbance to normal, and that in turn can induce ovulation in some women. However, which means male factor should be normal, tubal factor should. The only thing we need to remember, the risk, read the next line, which I have not encircled. The risk of multiple pregnancies increased with clomiphene citrate use alone or in combination with metformin. Therefore, ultrasound monitoring is important in clomiphene cycles. Monitor them on day 12, 13. If you find multiple follicles growing, then ask them to avoid intercourse. Now, there is a question, metformin versus evidence infertility and no other infertility factor to improve ovulation and clinical pregnancy rates. So metformin has a big comeback. If we are using clomiphene citrate, it is good to combine with metformin, especially in women who are obese and who have ovulated with clomiphene alone, but have not conceived with clomiphene alone. We can combine metformin. And as I told you, monitoring of combined cycles will need to be equivalent to clomiphene citrate alone. So whether you use clomiphene citrate alone or you combine it with monitoring, multiple ovulation may happen with both. So metformin doesn't protect from multiple ovulation, and hence ultrasound monitoring becomes important in these women. Now, a few pointers that when do you start ovulation in PCOS? You start on day 2, 3 or day 5, 6 or any day after withdrawal bleeding in follicular phase. So how do you know it is follicular phase? Say maybe the patient comes after 30 days of amenorrhea and says that, you know, if you can start treatment, start. So first is day 2, 3 of withdrawal bleeding or day 5, 6. If we started on day 2 versus day 5, then we are just 3 days earlier to cause the same changes with day 5 will cause a little later. So there would be more rapid follicular growth and multiple dominant follicles are more likely to develop if we start early with clomiphene. Can we start ovulation induction in any day post-menses? Well, we can start with variable results in anovulatory PCOS. How do you ensure that you can start after a month of amenorrhea? You want to start ovulation induction and the patient says that I have not had periods for the last 1.5 months. First thing I like to do is look at the cervical mucus by doing a PS examination. And if it has estrogenic mucus with good spin bucket, that means she's still in the follicular phase. If there's been no withdrawal bleeding, which occurred after giving her some withdrawal medicine like medroxyprogesterone acetate or norethistron, then if there is absence of withdrawal bleeding, first thing is rule out a pregnancy by ultrasound and beta HCG. And ensure when you start ovulation induction that endometrial thickness is baseline, which means however long the amenorrhea period may be, but if endometrial thickness is 4 or at the most 5 millimeter, you can start ovulation induction at that point only. After initial workup, can you monitor ovulation induction cycle without ultrasound? Well, with letrozole, I would recommend that no ultrasound, but with clomiphene, as you read in the guidelines, ultrasound has become important. But say if the patient is going out and she says no ultrasound is available, what can you do? You do a serum progesterone after 20 to 25 days of starting ovulation induction. Whatever happens, if she develops a dominant follicle, her progesterone will rise by day 20 to 25. After that, the drug has no effect. So a follicle doesn't creep up after 25 days, generally speaking. Exceptions could always happen, but a follicle will appear on day 18, 19, 20, any day. So a progesterone after 25 days of starting Y will tell us that she did ovulate, and please leave her without any drugs like dufaston or anything, assuming that she's ovulated. Let her menstruate on her own. That will give you a very, very clear-cut indication that a non-ovulatory patient took ovulation-inducing agent. Her progesterone rose or did not rise, but she had menstruation in, say, 30 days, 32 days. That itself speaks for her that she must have ovulated, a woman who does not get menstruation on her own. So this is how you get to know from a distant patient that she could have ovulated, not ovulated. You can start any day after withdrawal bleeding, day 2, 3, 5, 6, 7 also. Make sure the endometrium is baseline and make sure that we've ruled out a pregnancy in case there is no withdrawal bleeding. So this is all about letrozole and clomiphene. I'm not talking about doses because you all know the lowest dose is 2.5 milligram for 5 days. And if you want to give a higher dose, maybe obese patients, then 2.5 milligrams twice a day for 5 days. Let us talk about standard medical practices. Let us not deviate. There are so many combinations, permutations given. But if we are looking at evidence and we are looking at ethical practice, then this is how we would treat clomiphene, not milligram. Starting dose should be 50 milligram. If she ovulates on 50, do not increase the dose to 100. With letrozole, the same 2.5 milligram starting dose, you can increase to 5 milligrams. If she ovulates with whatever dose, continue the same dose for the next few cycles. If she doesn't ovulate with letrozole or clomiphene plus metformin, then we go to gonadotropins. Now, gonadotropins alone could be used over gonadotropins combined with clomiphene in women with PCOS. This is so important that I do not want you to think that you are reducing the cost. So it is better to use gonadotropin again, because if you use clomiphene and then you suddenly decide that I've given clomiphene from day 3 to day 7, and now I will give a gonadotropin maybe from day 7 onwards or overlap, or give it from day 10 onwards. No, because she might cause, again, you might lead to a great multifollicular development, because clomiphene does have action almost 13, 14 days after you have stopped the medicine also. So to avoid multifollicular growth, if she had not ovulated with clomiphene, whatever doses, then it is best to first wait for 14 days, see if there is no dominant follicle, the endometrium has not grown, and if you have facilities, the estradiol has not risen, then you can add gonadotropin. Otherwise, it is best to use gonadotropin alone. Use it from day 3, 4, 5, whenever the patient comes to you. It is not important that you use it on day 2 or 3 only you start it. In PCOS, they have big follicular reserve. So you can start gonadotropins late also, but don't overlap with clomiphene. Otherwise, we will be caught up in a situation with multifollicular development. So if there is clomiphene resistance or failure, whichever, it is best to give gonadotropins alone. And please remember the cost patient will take if you are giving her the right treatment and she gets pregnant. So read the sentence very clearly. Gonadotropins alone could be used over gonadotropins combined with clomiphene citrate in women with PCOS who are anovulatory and infertile with clomiphene citrate resistance or failure. So whether she's not got pregnant with it or she doesn't respond in terms of ovulation or with no other infertility factors, identify that there's no male factor, there's no tubal factor. Gonadotropins could be considered rather than combination of clomiphene citrate and metformin in women with PCOS who are anovulatory and infertile with clomiphene citrate resistance and no other infertility factors. So if you give clomiphene and you find that they are resistant, it is better to give gonadotropin to this patient rather than just combining clomiphene and metformin and waiting to see whether she responds or not. This can only be done in cases where monitoring is very difficult or where the patient cannot take up the cost at all for gonadotropin. So even though clomiphene with metformin is a good combination in cases who have not responded to clomiphene multiple times, but it is better to use gonadotropin rather than this combination. Gonadotropins could be second-line pharmacological therapy for women with PCOS who are anovulatory infertile with no other infertility factors and who have failed first-line oral ovulation induction, which means both the drugs have failed, letrozole and clomiphene. Now, we have to again remember that where gonadotropins are to be prescribed, the following should be considered. Cost of intervention, we need to tell, expertise required for the use of the intervention for ovulation induction, the degree of intensive ultrasound monitoring that is required, low dose step-up gonadotropin protocol should be used to optimize the chance of monofollicular development and the implication of potential multiple pregnancy. Because, we ask the patient, okay, have intercourse from day 10 onwards at least, so that you have a chance of getting pregnant. And maybe you find on the surface 5, 6 large follicles. Then there is always a chance of multiple pregnancies. So it is very important to monitor these cycles with whatever you want, ultrasound and maybe hormones also. So there appears to be no difference in the clinical efficacy of the available gonadotropin preparation. So whether you use urinary or you use recombinant, and in urinary, whether you use HMG or you use FSH or purified or highly purified, all these lead to the same efficacy, same pregnancy rates. The only thing with urinary products is that the biological activity is a little variable. It could be, say, a 75 unit could have a biological activity of 55 units to 90 units. So your response may be dependent on that. And hence, the question comes, we've already solved this question, which gonadotropin used and why, and what are your doses? Pen device or multi-dose vials. You don't have a pen device, there are all these HMGs also come as multi-dose vials, recombinant also come. Hello? Yeah.
రిపోర్ట్ తీసుకుని రిపోర్ట్ మోస్ట్లీ రేపటికి గానీ ఎల్లుండికి గానీ వస్తుంది రిపోర్ట్ వచ్చాక
Someone needs to be muted, Tejashree.
సేమ్ రాయడం
Someone needs to be muted, Tejashree.
Yeah,
Pen
done,
device-
ma'am. I have
Pen
muted
device
her.
or multi-dose vials are ideal for PCOS as it has the option for small increments of 25 to 50 IU, and this is only for PCOS. Please remember, I'm not talking about ovulation induction in women who normally ovulate, who are normal responders, or whom you are stimulating for IUI purpose with unexplained infertility. These are typical PCOS with oligo ovulation or no ovulation. So human menopausal gonadotropin FSH LH is 75:75. Urinary FSH preparations have FSH 75 and LH 1 part. Highly purified has the same composition of FSH LH, but the impurities are less than 5%. And the recombinant FSH is filled by mass. 75 IU is equivalent to 5.5 microgram. However, for our convenience, at every 5.5 microgram, there is a dosing of 75 IU. Now, how do you use gonadotropins and what starting doses in PCOS women for ovulation induction can you monitor without ultrasound? One is low dose regimes are used in step up and maybe step down sequential regimes also. The moment you step up and you see a lot of follicles are emerging and the estradiol levels have jumped up, that is the time when you need to just step down a little bit. Otherwise, always use in very small incremental doses. Ultrasound monitoring is a must, because these regimens fulfill two essential requirements for successful ovulation induction in PCOS: allow slow rise of FSH to just above the FSH threshold level, which is a very thin line in PCOS. And it could be very high also in them. So you may have to go on for days. Avoid explosive ovarian response because of extreme sensitivity of follicles to exogenous gonadotropin. Having said that, let us go to a very practical thing. What happens? A patient who is letrozole or clomiphene resistant did not ovulate in these two drugs. Letrozole 5 milligram a day, CC 100 milligram. So we think that we need to change over to gonadotropin, or this patient has not got pregnant on both these drugs and you want to change into gonadotropin. First lesson is the dose should never be more than 75 international unit as starting dose. It could best be 50, it could be 62.5 or 75. And you can start from day 3, day 4, day 5. When you're using gonadotropin, it is best to induce a withdrawal bleeding and then start in a stipulated time. First thing what we do is day 3 of menses, baseline endometrial thickness and ovary needs to be seen. What do we want in the endometrial thickness? We want a thin endometrium, something which is 2, 3, 4, or maybe at the most 4.5 millimeters. Thicker than that means that probably the earlier endometrium has not shed completely, and soil which is not healthy will not implant the plant also later on. So ovaries are quiet or they may have a simple cyst. If there is a cyst, it is best to do a hormonal assay also to make sure that the cyst is not producing any estrogen or progesterone. So this is all we do. Then you would start your gonadotropin, whether you've started 50 units or 62.5 or 75. Day 6 of stimulation. So if you start on day 3, it would be 3, 4, 5, 6, 7, day 8. If you start on day 4, it would be day 9. If you start on day 5, it will be day 10 of the cycle. You get a picture like this, that the endometrium is growing and a follicle has started to grow. Very good. This is a lovely picture. And hence you continue. Continue the same FSH, repeat ultrasound. Here the repetition has to come much earlier. Absolutely similar to IVF ultrasound monitoring, because we do not want an explosive growth. And it still happens despite being so careful. If any time you have in doubt that millimeter, I like to do a estradiol test. In the baseline, suppose if I also like to do a estradiol on the baseline, that makes me much safer, because if estradiol was 35 and it suddenly jumped up to 300, I know this is time when I need to stop the gonadotropin. And a follicle monitoring will emerge a follicle a little later, but estrogen rise indicates that a lot of follicles are going to emerge. And if we continue to give gonadotropin here, we have had it, immediately the estradiol will jump up over 1,000 and you will have a lot of follicles emerge. So till dominant follicle is 15 millimeter to prevent hyperresponse. The moment dominant follicle reaches 15, that is when you can stop your gonadotropin or dramatically use your dose, reduce your dose from 75 to 37.5, and ovulation will follow. Now, there is another set of patient where you've started the same regime. You are giving it for the first time. You have no idea. And day 3 of menses, you do the same thing. Then day 6 or day 7 or 8 of stimulation. I mean, it has to be after 5 days of stimulation. Depends whether it is day 6, 7 or 8 of the cycle, depending on when you started the gonadotropin. So here you find that a lot of small follicles are there. Endometrium has grown, but nothing has happened. After every 2 days, but you find that 2-3 days and there is no dominant follicle. The largest follicle is just 12 millimeter, as in this picture. So 18 to 25 days of incremental doses pass. You increase by 25 units, give it for 3-4 days. Then you increase by another 25 units, you give for 3-4 days, and you find no increase in follicle size. And I like to do a estradiol levels in these cases, because the follicle is not increasing. I want to know whether estradiol production has started to increase, because that increases faster than the follicle. And if that goes on happening and you've already stimulated her for almost 25 days, then you think of resistant PCOS. This is the most difficult group to treat. These always tend to hyper-respond when they respond, and they are very demoralizing for the patient as well as clinician. So please make your patients aware that you do not ovulate for months together, and don't expect that you will ovulate in 14 days like every other patient. Lucky if you do ovulate in 14 days, that means you've got very sensitive ovaries and very responsive follicles. But if you don't get disheartened. You may take even a month to ovulate. So that is one sentence which will put your patient to a little rest. And this happens in the first cycle when you recognize that, oh, I have increased the dose and nothing is happening. And I've given 25 days of gonadotropins and still a dominant follicle has not come up. So what are the problems? Follicles do not increase in size, nor the E2 levels increase. Endometrium also continues to be low. And sometimes there is intermittent bleeding also. And I've faced this so many times with gonadotropins, injections for 18 to 25 days with no changes seen, all follicles are 10, 10, 10, 10, just number of emerging follicles go on increasing. And when you jump up the dose, there is hyper response. And there is so much hyper response that you tell the patient, don't have sexual contact. And that is when the confidence of the patient and clinicians goes down. So what are the challenges in PCOS? One is respond to smaller standard doses of oral ovulation induction. You've given letrozole, you've given clomiphene, she responds, give her good 6 cycles of natural trial. If it doesn't work, do IUIs for her. If that doesn't work, then you think of other things. So this is a normal PCOS, a responsive PCOS. One is exaggerated response to clomiphene. Did not ovulate with letrozole, so you thought, let me try clomiphene, I'll give 100 milligram, and you suddenly find 5, 6 follicles emerge. Then you find another one, you've given letrozole 5 milligram daily, you've given CC 100 milligram, there's complete resistance. On day 25, you do a progesterone, it is still less than 1 nanograms. Then you give them FSH or HMG, and you see that you give in very small doses of 50 units or 62.5, and in 5-6 days, immediately a lot of follicles, the follicle emerges and you get a good response. When I say good response, that means the dominant follicle has come up and maybe few trailing follicles are also coming up. But as soon as one dominant follicle of 15, 16 comes, that is the time the smallest doses you're giving, don't go on giving that dose, let that follicle grow. Then you find that you are increasing the dose every 5 days, you are increasing by 50 units or 25 units, and 5 plus 5 plus 5 plus 5 times you've increased by 50 doses units, and it's still resistant. And then when you make the dose to something like 225 units of gonadotropin or HMG, then you find that suddenly they either respond or they hyper respond. So these are the problem group in PCOS who hyper respond. When we continue to give incremental doses, they don't respond, and then we make the dose go up to 225 and they hyper respond. We don't know what to do, because then we cannot allow them natural intercourse or IUI both. So there exists a definite group of anovulatory PCOS with all of us encounter who appear to be resistant to ovulation induction when treated with small incremental doses of FSH over time for the purpose of ovulation induction. We are not talking about IVF cases at all here, because their multifollicular growth is desirable. We are talking about normal patients who want to get pregnant without IVF. So we thought, what could be the underlying factor, and how do we identify these patients in the first go? When do we start suspecting that this one could be that resistant, gonadotropin resistant PCOS? We thought, let us look at the BMI, let us look at the AMH levels, let us see their LH levels, and let us see how hyperandrogenic they are. So we did a study over here in Gangaram Hospital in 2016 or 2017, where there were 18 patients over a 6 months duration who were selected from a cohort of clomiphene-resistant women undergoing FSH stimulation for ovulation induction. And we found that about 20 to 25 days, none of them responded with incremental doses. There was no ovulatory response in terms of rise in serum E2 levels, at least rise of 30 picograms per ml from baseline, or presence of a follicle greater than 13 mm or larger. This did not happen, even after 18 to 25 days of stimulation with incremental doses of recombinant FSH of up to 150 units. See, when you increase from AMH is very high, 65 units, after 5 days, you'll bring it to 100 units, another 5 days, you'll bring it to maybe 125 or 150 units, and there's no response, then you say that this is. So Journal of IVF Reproductive Medicine and Genetics in 2016, where we did a series of 18 cases of clomiphene-resistant anovulatory women with polycystic ovary syndrome and altered response to FSH stimulation. Now, these women were labeled as FSH-resistant PCOS and were further stimulated with higher doses of injection HMG. The starting dose of HMG was 150 units, which were subsequently increased to 225 units if there was no response after 6 days in terms of rise in E2 and ultrasound evidence for dominant follicle. Surprisingly, all the patients responded or hyper-responded within 10 days of stimulation of giving such high doses of HMG, which has LH activity, FSH activity, both, and a very high dose for a AMH of 15-20. So we looked at all parameters and we said, let us see which is common in all. What did we find? BMI was high in all these women. So waist circumference ranging, BMI ranging from 29 to 36 kilogram per meter square. It was 33. Then what we found, another thing, was AMH was extremely high. Now this value is in picomoles, 60 to 145 picomoles. So 60 picomoles make about 9 nanograms and 145 makes about 20 nanograms. So AMH was so high, up to 20 nanograms. Rest, if you see, LH was okay, FSH was okay, LH variation was 3.3 to 12 maximum. So the mean was 6.4 only. Oral OGTT, lipid profile, ovarian volume, antral follicle count. And we also looked at the hirsutism parameters, which I have not brought the chart here. It was not this that these women who were there were more hirsute. There were ones who were less hirsute. The most common feature was high AMH. So we thought that why don't some PCOS respond to exogenous FSH when administered in appropriate doses for ovulation induction? One is very high AMH has an inhibitory effect on follicular recruitment, especially on low dose step up FSH administration, which is used for ovulation induction in women wanting to conceive naturally. Another thing is that it's been recognized that there is FSH receptor polymorphism in some women, and this makes follicles resistant to lower doses of FSH, even in IVF, and higher doses of FSH are required to overcome this. Here, maybe the baseline FSH could give us a little indication in a woman with AMH of 12 nanograms and a FSH of more than 8, the baseline. Probably should ring a bell somewhere that maybe she might have FSH receptor polymorphism. When we look at possible actions of AMH in the ovary, then we see that it inhibits follicular activation and growth, inhibits FSH stimulated growth. It also inhibits granulosa cell growth and the aromatase enzyme. So right from the primordial to primary, it has an inhibitory role. You see there is a minus point here in this diagram and a minus point here also. This is AMH, and FSH causes follicular recruitment and growth. So that has a plus effect when we say talking about preantral to antral and follicular growth in the gonadotropin sensitive phase of the cycle. Having said that, FSH receptor polymorphism has been recognized along with 5 beta LH gene mutation. Now, which receptor? It is FSH R serine 680 variant is high in hyporesponders with good ovarian reserve, and consumption of FSH is higher in carriers of this polymorphism. Even in IVF, you'll be surprised that you look at an AMH of 8, 9, 10, and you decide I will not give her more than 150 units or 100 units, and suddenly you find that the response is very, very low. So these are possibly patients who have FSH receptor polymorphism. And there is another 5 beta LH is a common genetic variant of LH beta subunit gene and is associated with higher exogenous FSH consumption, as well as probably addition of LH is required in these patients to cause follicular response. So resistance to FSH in PCOS, non-IVF OI, ovulation induction is very difficult because you have to make small incremental doses of FSH, and if it shows resistance due to high AMH or FSH receptor polymorphism, you've had it. But in IVF, it is so easy because we don't ovarian stimulation. controlled ovarian stimulation for IVF, where you start with higher doses. I mean, irrespective of the AMH, we generally like to start with 150 units. There, you could overcome this polymorphism or the resistance because of very high AMH much more easily, rather than when you start with 50 units or 62.5 or 75, you lose a lot of time in going for incremental doses. And if you recognize such patients during stimulation only in ovulation induction and natural conception, and eventually you find that whenever you increase the dose to 225 or 150, they hyper respond, you counsel them for IVF, because you cannot allow IUI or natural intercourse in women who have 5-6 dominant follicles of 17-18 millimeter. Undoubtedly, they will leave hyperstimulation is one on one side, but multiple pregnancy is a very sad story, because if they have triplet, quadruplet, and they go for reduction, a lot of time the whole uterine receptivity is lost in these cases. So if you've identified in IVF, please beware, start them with a higher dose, because over there also you would get the same type of response which you got in ovulation induction. So resistant PCOS, very high AMH, FSH receptor polymorphism, 5-beta-LH gene mutation, all can be overcome by high starting dose of FSH or HMG as in IVF. And so the last word to ovulation induction is, if the diagnosis is correct, most cases will ovulate. Aim is not to achieve ovulation at the cost of increase in complications such as OHSS and multiple pregnancy. Days taken to ovulate do not matter at all. When patients are oligo-ovulatory and they ovulate on day 30, 35 and get pregnant on their own, doesn't matter they've ovulated on day 14 or day 30 or day 40. Once they've ovulated and they've been exposed to a chance of pregnancy, the pregnancy will be as healthy as ovulation would have occurred on day 14. And we have to remember, ovulation induction is not only a science to learn, but it is a piece of art practicing. Now here I have got 2-3 questions for the audience. Scratch your brain. The lecture is over. Everyone is there now. Tejashree, can you hear me?
Yes,
you
ma'am.
hear me,
Everyone is there,
Tejashree?
and we have few questions. Yes, ma'am. So we also have few
Yeah, you
questions
start
from
with
the
questions,
audience.
then I'll put this. Yeah. Start with the questions, and anyone
Okay.
can ask questions after Tejashree has asked, and please be open to discussion, because the whole motive of this is that everyone can ask questions and we can, sort of answer. Yeah, come on.
Yeah. So first
Start
question
with the chat.
we had is first question. Can you hear me, ma'am?
Yeah, very well.
Yeah. So first question is that in a patient of PCOS with an AMH of 9.6 nanograms per ml, if the day 2 LH is 0.9, what is the next step that you would advise?
Nothing. LH doesn't matter at all. You're talking about day 2, no?
Yes, ma'am.
So,
A similar kind
day
of
2,
question two people are asking, whether there is any cutoff for the serum LH level on day 2 where you won't start any stimulation.
please understand that LH was given a lot of importance in the past, and we were sort of scared of high LH levels and low LH levels both. But now it has been clarified by so much evidence and so many studies that whether the LH is low, if the LH is low, please make sure that she's not a hypo patient and the FSH is not low. But then she wouldn't have a polycystic appearance of the ovary. So if the LH is less than 1 on day 2, please do not be afraid. Start any of your ovulation inducing agents. The FSH will rise and the LH will also rise. Same thing if the LH is even 20. Don't go for oral contraceptives to reduce this LH, because it will naturally go down as FSH goes up.
Okay, yeah, that's a good insight, ma'am, that the LH levels really don't matter on day 2. The next question is, how long can we continue stimulating before we need to cancel a IVF cycle for no response?
Say again.
So how long can we continue stimulating before we need to cancel a IVF cycle for no response?
See, if your diagnosis is all right and you've done a FSH, LH, estradiol beforehand, and this is not a FSH, LH which has been done after you've given OCPs to the patient for a couple of months. So you know this FSH is the original FSH and LH, you will be able to stimulate your case. And you can go up to 225 units or even 300 units if you think that this is sort of a little growing as much as you had thought. Abhi, a case of IVF, they have been barging me with this, that it is already 10 days of stimulation and follicles are only 14, 14, 15, 15. But if estradiol is rising, don't be afraid, it will go up. You can go up for 14 days, 15 days, 16 days also, till your dominant follicle touches 17 mm. That is when you give a trigger.
So recently we had this
So
patient,
don't
ma'am, who
think that there is very low reserve. We are talking about PCOS right now. I also could
yes.
see Pallavi's question. So if there is no response, it is generally in responders happen. But in PCOS, there will be a time when you will get a follicular growth, maybe 14 days, maybe 15 days. Sometimes they are slow bloomers. So if your diagnosis is correct, you will definitely get a follicle. I will come to you with your question, Pallavi. Here, if you see, there is a question which I put. Can you think of PCOS, which means high AFC and AMH, with amenorrhea, but no progesterone withdrawal bleeding, nor can these be stimulated with any doses or length of gonadotropin stimulation? Pallavi, this is a question for you. Can you answer this? Anyone can, is everyone muted or everyone is now open to answer? Pallavi?
So right now everyone is muted, but I can unmute.
Pallavi
If
को unmute
somebody
करो.
can put up their hand, I can unmute them.
So anyone
Hi,
wants to
Pallavi, can
answer
you
this?
hear us?
FSH receptor resistance.
No. This is, yes, very good. It is FSH receptor resistance only. And here what will happen? You just do a FSH and you will find that this is very high, which you had not thought of before, because maybe she was getting OC pills for a withdrawal bleeding, thinking that high AFC, high AMH. And that's why I'll just change the slide. High AMH, high AFC, and very high basal FSH. I thought this lab is wrong when I had the first case in my life. And I said, oh, repeat it and we will make your eggs. There's no problem in this. And my FSH was 100 MIU. And then we said, this is FSH receptor resistance. So remember that high AMH, high AFC, if you have resistance, either there is complete receptor resistance, then FSH will be really high. But if there is polymorphism, FSH still could be high as much as 10, 11, 12, whereas PCOS should be having low FSH. They can have high LH, but FSH should not be more than 3, 4, or 5. So in non-contraceptive preceded cycles, it is very important to see the basal FSH. You can give a progesterone withdrawal, do a basal FSH, or if she's in a period of amenorrhea of 2 months, straight away do her FSH, LH, and E2. And that is her basal FSH, LH, E2, because she's not ovulated for 2 months, so it is basal whenever you do it.
Ma'am, there is a
Could you
question
understand?
here.
Yeah.
Yeah, so there is a question here where somebody is asking that if the endometrium is growing well, but the follicles are still small, and sometimes the patient starts shedding and she starts getting spotting. So what can we do in that cases?
Now,
The
here,
endometrium
this is a
is
tricky question. This even happens with letrozole cycles and sometimes in clomiphene cycles, that if the estradiol does not increase and the number of follicles are increasing and the endometrium remains the same, endometrium is like small, it can break in between because either the injections are not working. It is the quality of the injections from where you buy. Unfortunately, our market is full of spurious injections. So this could be one reason, or you have to give a higher dose. Now, ET, you are writing is 13, 14 mm on day 14, 15. What is
Yeah,
it? Good
so
evening, ma'am.
that's,
Is there any
yeah,
difference in treatment between resistant PCO with no response in endometrium
with
and
the thin
another
ET,
patient with
another
resistant?
having a thick ET.
See, thick ET has to be dealt with before you start stimulation. So once you are starting stimulation, you will always do an ultrasound for all PCOS women to see whether ET has come down to 4 millimeter. In that case, your ET cannot go up to 13, 14 mm on day 14, 15 without a follicle emerging. Estrogen kahan se aayega? You understand? Yes, there could be some PCOS whose endometrium is hyper responsive and the endometrium grows much faster, but the follicle will come up. On the other side, you are asking PCO with no response in endometrium, that means ET remains low. These are very androgenic PCOS. These are women who have high androgen, and we've known that 10% of women who have PCOS are very androgenic, and androgen receptors are found in the endometrium, and that sometimes leads to a low ET, low implantation, low pregnancy rate. So in such cases, maybe using, I don't know the treatment, I looked in the literature for such cases, the only answer would be use an anti-androgen for 3 months, maybe prior to taking her for embryo transfer or for implantation. So endometrium doesn't have a response according to whose question is this? S. So see, both the things have to grow together. If the endometrium has grown too much with follicles coming up, it is understood that the endometrium is hyper-responsive to estrogen. If the endometrium is less with follicles coming up, then it means that endometrium is less responsive, and this happens in very hyperandrogenic women. And maybe you can treat them with Diane or spironolactone for 3 to 4 months, and then take them again for a stimulation. But this doesn't happen, what you're saying. I've never seen this happening, that if a follicle doesn't come up and the endometrium keeps on growing to 14, 15, I mean to 13, 14 on day 14, 15. So please write questions where you have really seen patients having this effect, and then we can do a research on this, that, you know, nothing grows, but endometrium is thick. This happens in natural PCOS who are exposed to estrogens, unopposed
Who are
estrogen.
very sensitive to even low levels of estrogen, and
Yes.
their endometrium becomes
Yes,
very
so
thick.
such
But
PCOS, just, yeah, Tejashree explained this, because
yeah,
endometrium will grow without any ovulation over
without,
here.
yes, they are sensitive to even very low levels of estradiol, and that's why the endometrium is ahead of the follicle size. But I think, ma'am, if this is happening during stimulation cycle by gonadotropins, we can find out looking at the E2 level whether the follicles would be coming up. If the E2 levels
Yes,
are
and
rising, the
follicles
follicle
will
will
coming up.
certainly come up.
Yes, and an endometrium of 13, 14, 15, according to the latest evidence, we had a presentation in class. Don't
Doesn't
cancel your
matter
cycle.
really.
It can
Yeah,
always be, embryo can be transferred
can lead to
cycle with
implantation.
much thicker endometrium. So
Yeah,
if
one
the
of
E2 levels are growing from baseline, you know that a follicle is coming up.
coming up. Yeah. Ma'am, there is one Dr. Neeraj who wanted to know that if something can be done to improve the quality of the oocyte in
Yeah.
a patient who was where he got 22 oocytes but no embryo was formed.
Dr. Neeraj, this is a case of IVF. This is not PCOS, and we are really looking at questions which are relating to PCOS. So anyways, now since you've asked this question, it could be oocyte quality, it could be sperm quality, it could be the culture media where you have 22 oocytes, and is there complete fertilization failure? So we must know that also, which is TFF, which means that no 2PN was formed. Or is it this, that 2PNs were formed, but then on day 2, day 3, you had nothing? So it has lot of grades over here, and that becomes a more of IVF question rather than a PCOS question.
Now, two of the doctors, I think these are last two questions we'll be taking. Dr. Madhura and Dr. Jyoti both want to know that what should we do in cases of FSH resistance and how to proceed.
See, FSH resistance, you can do nothing. My patient of FSH resistance, which I'm telling you had a FSH of 100, I could do nothing. You can't stimulate. There has to be some autoimmune thing which has made her FSH receptors resistant, and you will have to go for a donor egg. And this patient, Ankita, had to go for her sister's donor egg because you cannot stimulate her own ovaries unless somehow, the resistance is sometimes fluctuating, especially if it is autoimmune in nature. And if it
I
is
think
autoimmune in nature, she might
is
even
a
have a withdrawal bleed. But such patients always have a thin endometrium, high AFC, high AMH, and whatever you give them, the receptor is resistant. So you give FSH as much as you want, nothing will happen. So you will have to go for donor oocyte IVF. And once you have identified it, you should be able to identify, and then you do this thing. Counsel her and tell her that, yes, this is an interesting question. Can we use IVM? Maybe in these patients, you can do IVM. From all the follicles, try to get oocyte and grow it in vitro and see, because the FSH receptors are not there in vitro. So maybe the oocytes can grow in vitro. Whose question is this? This is a very good answer. Can we use IVM? Maybe. I think this is a very important question, and all of you find literature out and see that if there is FSH receptor resistance, IVM should work theoretically. There is no role of long agonist protocol in this, because however much you suppress FSH levels, these are serum FSH which goes down. The receptor resistance is sitting as it is over the receptors. So whatever doses of FSH comes, whether it is endogenous or exogenous, the receptors are resistant and they will not work on, the molecule will not attach to these receptors. So there is no effect which will come, no gonadotropin will be able to stimulate the ovary. Because when 100 MIU basal levels cannot stimulate the ovary, then adding 20 to 25, 300 or 600 units are not going to cause.
I think we are done with all the questions, ma'am, and thank you so much. That was really an insightful talk.
I have two
we all
questions
have
for the
learned.
audience. I have two questions.
Yeah, sure. Yeah, yes.
So one is this, that I asked you this question, PCOS with high FCAMH. So we already spoke about FSH resistance, and the only thing which identifies it is that you see a polycystic morphology, you do AMH, it is high AFC. But FSH level initially is very important to determine whether it is FSH receptor resistance or not. So don't forget that AMH is the total answer to all these PCOS-like ovaries, because one day you will get caught up in a case which will have receptor resistance, and there no drug, no dose, no length of stimulation will help. So this is one thing I wanted everyone to keep in mind, that when you do this, once when the whole slate is quiet and there's been no agonist given earlier or no OCPs given earlier, do one FSH level. And another question is, now I want an answer from all of you, because I have an answer, but I don't know whether it is okay or not. So all of you tell me, a young single woman with underlying PCOS, that means high AMH and AFC and normal FSH, like condition with long periods of amenorrhea, but no progesterol withdrawal bleeding happens. On scanning, I find after 3 months of amenorrhea, the thickness of endometrium was 3.5 mm. So progesterone withdrawal will not happen. She has history of hyperlipidemia and also has had her Doppler done of the legs for calf pain, and there was like a chance of DVT. So OCPs are contraindicated for her. She desires regular menstruation. How will you treat her? Anyone can write in the chat box or raise your hand and speak. I would love to have an answer to this. No, she's not allowed ENP, bhai. Low doses, she's not allowed estrogen at all.
Ma'am, steroid?
Steroid, how will steroid help her?
maybe say
Estrogel could be one
hyperandrogenism.
answer. Estrogel could be one answer, that maybe estrogel we can give her, so OCPs are contraindicated, hyperlipidemia is there, so dermal estrogel could work. Bhavani Shekhar has written ovulation induction. What ovulation induction will you do? She's
Ma'am,
unmarried.
letrozole. Letrozole.
Yes, I thought of it, but I could not find this answer anywhere. See, letrozole we use in cases of breast cancer, follow-up cases, whether it's young or older women. If estrogen receptor is positive, we give letrozole for years together nowadays. Nowadays, tamoxifen is gone because it causes endometrial hyperplasia. So if letrozole can be given for years, why can't we give letrozole from day 2 or 3 for just 5 days? And if we can induce ovulation in her every month, then she will get a withdrawal bleeding. There'll be no risk of high estrogens. There'll be no risk of giving OCPs. Even if we want to use gel, like someone said, you use gel and then give her progesterone, that could be one option. But how will letrozole harm her? I don't think. When letrozole can be used for years, and there is a girl who just had a call with me yesterday on Zoom, whom I had given letrozole for regulating her menstruation, and now she's got married in October, and she said all 3 months she got her menses, but she's not pregnant and she's taking letrozole. So I want anyone to come up that, does it look wrong to give letrozole, or we could really give it? What is Linzit spray, Rita Darbari? Yeah, Madhura, estradiol ring or transdermal patch is not a wrong option. It could be a good option. And we can give her progesterone withdrawal. Right, we can do this also. Transdermal patches are not easily available. Estradiol ring, an unmarried girl may not want to wear. So, Tanu, your question is, can letrozole be given for a long time for regular menses? Because clomiphene is a drug which has a bar on its duration use. Letrozole, I don't think anyone has read that there is a bar. How can spironolactone act, Nisha? No. Not on a daily basis, just 5 days a month. Right? So I don't think it is wrong, but I could never find it in books. And there are 2-3 girls who come with an absolute thin endometrium and they don't want to take OC pills. So either maybe what someone suggested, a gel with meprate withdrawal will do, like they do in hypo. I don't give them oral estrogen. We give them gel only. Or we will have to resort to letrozole. If there's any harm in giving letrozole, please find out, write on this forum, even tomorrow, and we will look into the literature and see and discontinue using letrozole. Right, Tejashri?
Yes, ma'am, that seems to be quite a promising approach to long-term anovulation
Ma'am,
and thin endometrium.
in between, there were some studies that it can cause malformation, but then it was proven beyond the doubt
I'm
that
talking
there
about
were
the unmarried
no
girl,
malform.
a young single woman. But I don't know, in between, no, letrozole had gone off label when they said that it has more congenital malformations than clomiphene, but it came into use
Yes, ma'am.
after some time that no, the malformation rate is equal equal to clomiphene.
Clomiphene. Yes.
In a young girl, why would you want to, Dr. Jyoti, do a laparoscopic ovarian drilling for her periods to become normal? I don't think laparoscopy is really a very good option for her. But yes, gel followed by a progesterone withdrawal could be one option, or a patch or a gel, not a ring, because she's a young girl, may not want to wear a ring in the vagina. Or letrozole could be another option. So read, see, and if you could find any article indicating this, I would be very happy. Otherwise, I will stop letrozole and start using the gel with
Your voice is breaking, ma'am. I
right.
think there's a
My
connection issue.
patients.
Yeah,
Acha,
now
there
you're
is a-
audible. Yeah.
Okay. Sangeeta
It
Milap, I'm
was
so happy to see you. You're sitting in USA. क्या time है वहाँ पे? Early morning?
Yes, ma'am.
It's early morning, and I saw you speaking, so I said I must listen to you.
Wow, how nice is that? Wow. Now,
I
Sangeeta is a
really
girl.
enjoyed you, ma'am.
Sangeeta, tell me, are you on letrozole?
No, ma'am. I'm on exemestane.
Acha, what is that? After your
It's
cancer?
aromas and
Nahi, it must
exemestane.
be a aromatase enzyme inhibitor.
Yeah, ma'am.
Yeah,
Yeah.
so it is like letrozole. It is like an
Yeah, like
estrogen.
letrozole. Yeah.
Yeah,
Yeah.
so I don't think if you're taking it for months and years, 5 days of use every month could be detrimental to her having her menstruation.
Yeah. I think, ma'am, that's a good idea.
Yeah, and rest, the other idea which I liked, which who gave, I think, who gave that idea, which I loved, that you can use a gel. Yes, I do use gel. Madhura. Madhura gave
Yeah.
this, right? Madhura, where
Yeah.
are you? I think she wrote this. Any role of Dexa का कोई role नहीं है. Minoxidil का कोई role नहीं है. Minoxidil, I'm not really aware of it because I don't use it, and it is not a standard ovulation inducing agent. And ANP at low dose नहीं. Estrogel Tanu ने लिखा है, which is a good option. And
Ma'am, progesterone, can't we give progesterone withdrawal bleeding?
she has an endometrium which doesn't grow more than 4 millimeter even after 3 months of amenorrhea.
Okay.
And such women have a very low chance of endometrial cancer because of PCOS also later on.
So that way, letrozole is the only answer, it looks like.
Letrozole or estrogen cream,
Yeah.
a transdermal patch or something, which where she doesn't have to take it through the liver. But that also we'll have to take permission from her DVT treating doctor. That can be put her on. I think we can put her on a transdermal patch. Bhavani, what do you think? Bhavani? Dr.
Yes,
Bhavani,
ma'am.
what do you
Transdermal
think?
patch
Can we
should.
put her on a patch or estrogel?
Yes, ma'am.
It
Patch
should be
or
safe. It should be safe where oral
with
estrogen is.
hyperlipidemia.
Okay. So you
Yes,
think that it should be safe where estrogen is contraindicated, oral estrogen, right?
yes, ma'am.
Anyone else? Yes, Shilpa Sood, clinical picture, you are right. Sometimes you could have hypothalamic amenorrhea and with underlying PCOS also, but then over there also the FSH-LH is very low when you do a baseline FSH-LH, like if there is no period for 2-3 months and you do FSH and you find it is 1.5 to 2 or less than that or less than 1, then you say it is hypothalamic amenorrhea. But if FSH is 5, 6, 7 and AMH is high, then it is not hypothalamic amenorrhea. Am I right, or someone wants to contradict? Neeraj, why PCOD patient will have thin endometrium after 3 months of amenorrhea? You have to see more cases, Neeraj, and you will find one odd patient. And where you give medroxyprogesterone has not worked, you call her and say, let's see your endometrium, and you find that it is very thin, and that is why medroxyprogesterone withdrawal did not lead to bleeding. First thing is you have to rule out pregnancy. And what we do before giving medroxy is just look at the endometrium and make sure she's not pregnant. You can't use Gunjan, Progenova. I don't know Progenova is to be used vaginally or not. But I think a gel would be safer for her. And why would we prime her for 2-3 months? We can give it every month, or we can give it every 45 days, Meprate withdrawal. But oral, I don't think we would give. And vaginal, I don't know whether these will work, like you've written Estrabed, Progenova. I don't know whether they work vaginally. Anyone has an idea? Do they work vaginally? Bhavani, Tejashri? Tanu? Yukti?
Haven't heard of, ma'am.
Never heard, no? That we use bromocriptine vaginally and Acha, you do it in FET preparation. You give Progenova vaginally. So we must read about this. Can you post, Gunjan, on the same forum a paper which says that they've used estradiol valerate vaginally?
Yes, ma'am. We are also using estradiol
Estrabate.
vaginally.
Acha, who's that? Who said we are also using?
Neeru, ma'am. Dr. Neeru Takrar.
Okay, so please post an article which says that these will work equally well vaginally, and it would be very nice to know. And if we are doing vaginally, then it goes through the first pass to the uterus like progesterone goes. So it would not have high blood levels and may not alter the coagulation profile.
Okay,
Is
ma'am.
there a certain group of patients where you give it vaginally, or is it a
Yeah,
routine practice that?
patients who are not tolerating orally and they don't want to take orally. And especially when, in spite of estradiol, their E2 level is very low. So their vaginal is comparatively better acting.
But please take out an article and please forward it
Yeah.
on this forum only. Then we'll all get some material to read.
Patients who are
What?
LFT raised
No,
on
no,
those.
we all should learn from this. You will learn, I will
Hmm.
learn. But I need to know if these are vaginally better absorbed. And I would
Hmm.
also want to know that those who are not tolerating orally, maybe we can give them the gel, the dermal gel, which is supposed to be given on the skin. And
So
that
instead of 6 milligram, vaginally we have to give only 2 milligram. Equal effect come, lining become even in the single
please
tab.
put the article, Neeru. Please put the article. I'll be very happy. We learn something today then. You know,
Yeah.
all of us are here to learn. So you
Yeah.
please put this article on the same forum, on the
Because
same.
for these indications, we do use the dermal gel,
Yeah.
but we haven't ever
Yeah, gel
used
also we
tablets
require
which are.
higher dose. Vaginally we require very less dose.
ठीक है, you please put the
Okay.
article from wherever you got this information on this forum of ours. We all will get to read that article. All right, Neeru?
Yeah, okay. Thank you so much, ma'am. I think it's already past 8, and
Yeah,
it was a very nice discussion that we had today. And thanks to you for this initiative. And we will continue this presentations and discussions every week.
And you know, we will have practical points only. Right now, I took something for all the gynecologists. IVF is a later thing which we will come to because all of our gynecologists don't practice IVF. So think of a good topic and we will
Topics which
take it next
everybody would be
Thursday.
interested.
First, we'll take a
Yes.
few topics which everyone will enjoy and then we'll go up to IVF. Okay?
Yes, ma'am. Sure. Thank you so much, everyone, for joining today, and we'll keep you posted and updated on the WhatsApp group. Those who haven't yet joined, please let us know. Please let the Intas people know, or let me know. We'll send you the link to join the WhatsApp group as well. Thank you so much, ma'am. Thank you.
Thank you. Good night.
Thank you. Good night, madam.
Thank you, Tejashri, for moderating the session. And
Thank you, ma'am. And thank you,
Neeru,
Dr.
a very
Vishal,
good
for.
comments. You will put a article for us to read so that we'll also know, and if it can be used vaginally, we will use it safely then.
Sure, we'll try and find out that use.
Yeah.
Thank
And
you.
what is its effect on hyperlipidemia also through the vaginal route? And
Absolutely.
if it has no effect,
Yes.
excellent. All right.
Okay.
Okay.
Thank you. Good night, ma'am. Thank you, everyone. Thanks.
Bye.
Good night.